Recording has started.
Thank you, sir. Okay, we do have a couple of folks that are on phone numbers. If you could please identify yourself. The one with 443-834-4670.
You've been unmuted. If you can introduce yourself, please. Phone number ending in 4670. Are you able to unmute your line and introduce yourself, please? Oh, looks like they're leaving.
All righty.
All right. Okay. Well, welcome everyone. This hearing of the New Mexico Department of Health Medical Cannabis Advisory Board will now come to order. I'd like to welcome you to the public hearing where the Medical Cannabis Advisory Board will approve the previous meeting minutes, establish quorum, and receive updates from the medical cannabis program. Additionally, we will consider discussing a previous petition that was tabled at our last meeting regarding a new qualifying diagnosis for the Lynn and Aaron Compassionate Use Act. We will also hear comments from the public and schedule our next meeting for 2025. So pursuant to notice, this matter is being heard the 7th day of October 2024 via a web-based platform and is being recorded. The time is 9:19 and I'm Stephanie Richmond, the chairperson for the Medical Cannabis Advisory Board. The New Mexico Department of Health Assistant General Counsel Chris Woodward will be advising the department during this proceeding. This proceeding is being held in accordance with the Lynn and Aaron Compassionate Use Act, Section 26-2B-1 through 26-2B-7 NMSA 1978, and regulations at NMAC Title 7, Chapter 34, Part 2. If members of the audience have not already registered for this event, please register online so that your attendance may be noted and included with the advisory board submission to the Secretary of Health. I'd like to thank my fellow board members for joining today's meeting. At this time, I'd like to introduce each Medical Cannabis Advisory Board member and take roll call in alphabetical order. After my introduction, please announce your training, specialty, and interest in the Medical Cannabis Advisory Board. I did not see Eileen Barrett on the line. Is she present today? No.
She is not.
I also did not see Mordecai Bronner. Is he on the line today?
He is not.
Okay, thank you. And then T. Kosei. Oh, I see in the chat that Rachel does not have an option to unmute.
I'll take care of that. And T is here.
Excellent. T, thank you for joining us today. Please introduce yourself and advise us as to your training and interest in the Medical Cannabis Advisory Board. Looks like she's also having, she's not able to unmute.
Okay. Oh. Well, I've enabled her.
Yeah, it does show that she's enabled. Make sure that you are unmuted on your end as well, because you should be able to. All righty.
Okay. Okay. We see, she responded that it is not working for her to be able to unmute.
So can we announce if they put them in the chat? Can one of us from the department announce their name and their credentials?
Yes. Yes, that would be great.
Okay. Okay, so Bettina Kosei is represented as present, and her area of practice is family nurse practitioner.
Excellent, thank you. And then Rachel Goodman.
Yes, I'm Rachel Goodman, OBGYN here in Santa Fe. And what else would you like me to say?
Your interest in the Medical Cannabis Advisory Board. Thank you.
Oh, yes, I've been on the board for a long time now. I don't know, maybe 9 years. Yeah, I've just seen it grow and change, and my interest has continued to watch how it has evolved and seen the benefits of cannabis for my patients. So excited when we have a women's health topic as well.
Thank you.
Thank you.
Cindy Griebler.
Hi, my name is Cindy Griebler. I'm a family medicine doctor, and I've been interested in medical cannabis for a number of years, and my interest is making sure to keep medical cannabis safe so that it can be used not only recreationally but specifically for medical uses, and done so in a way that people understand how to use it and make sure that they are see, like, that people are able to see whether this is an option that might work for them for different kinds of medical uses.
Perfect. Thank you for joining us today. And Sabrina Johnson, I'm not sure, she may be having some. Oh, perfect.
Okay, it said I can unmute now, but I have video disabled, so sorry you can't see me. So I'm a background in family practice primarily. I'm a PA, but all primarily underserved rural health communities. So complex, lots of problems at once that you're treating. So lots of polypharmacy. So that's my main interest in cannabis, just because it has been so safe and we can treat so many things at once and avoid a lot of pharmaceuticals. So I am an advocate for many reasons across the board for cannabis. So just excited to be part of this, to make it available as an option to our patients.
Thank you. I also see that Ellen Plymall is joined.
Good morning. Alan
morning.
Plymouth from Deming. I'm a clinician, an internal clinic twice a week, and enjoy what I'm doing with the cannabis program, and hopefully we can keep benefiting patients.
Thank you for joining us this morning, Ellen. My name is Stephanie Richmond. I'm a PA, and echoed similar thoughts for our other board members with my interest for the medical cannabis program, just being able to expand this access for different diagnoses. So next we have Tracy White.
Good morning, everybody. This is Tracy White. I am a pharmacist clinician in Las Cruces. I work at the outpatient cancer center. My interest was working in hospice care about 15 years ago, kind of being introduced to helping patients work with cannabis as a medication, and that has continued throughout my practice, and now primarily working with cancer pain and symptom management for oncology and palliative care.
Excellent, thank you. All right, there are 7 of 9 advisory board members present today, and we have therefore established quorum. We'll now proceed with the hearing agenda. A motion to approve the minutes of our last meeting that occurred on May 13, 2024, from documentation that was provided to the board prior to this meeting, and our previous meeting was recorded and may be viewed on the Medical Cannabis Program webpage.
I move we accept the.
Thank you. Alan seconds, approval for the minutes. At this time, I invite the Medical Cannabis Program to update us regarding their activity and progress.
Okay, good morning, everybody. As you can see, Dr. French is on vacation, which we're very happy he's had that opportunity. So I'm going to be providing the update today. Just a couple of things. I know last time we talked about the DEA looking at rescheduling of cannabis from a Schedule 1 to Schedule 3. Public comments have closed on that, and we are awaiting a final decision. I imagine if decision is going to be made, it will be made after the election. I believe that there has been some stalling on that until the election actually occurs. So once that does change, we do anticipate that, you know, there will be some changes. There won't be a lot of changes, I should say, because even though it's a Schedule 3, like it would not impact our program at all. It would just make it more readily available for research and maybe hopefully provide providers with more comfort in recommending that. You know, there are a couple of items that they would have to go through FDA approval to be used, like vape pens and items like that. So it will be very interesting when this does change. Our enrollment remains steady at around 79,000 active patients. One thing we have noticed over the last few months is anxiety disorder has taken over cancer to become our third most frequent diagnosis. One other thing that we're working on that I did not include in the presentation is we have recently presented to the legislature a white paper on psilocybin and MDMA treatments. So that is kind of boiling in the background that we may be looking at some treatment modalities around using that for some of our conditions. Big news is that our office has moved, and we are now located in the Harold Reynolds building in Santa Fe. So our new address is 1190 St. Francis Drive, Santa Fe, 87505. Our address remains the same, email remained the same, but they have relocated us into the Harold Reynolds building. So that was a fun 2 weeks for us when we packed up to move. It was a little bit, not a surprise, but it happened a lot faster than we had anticipated. But yeah, we're glad to be over in the building with everybody else. I just want to do a real quick presentation today. Our staff continue to work diligently on applications. I believe our average processing time from the day a completed application is submitted until approval is running right around 0.8 days. So we are under 1 day for approving applications when they're submitted. So the online process has been an incredible improvement for patients, and we're extraordinarily proud of that. So, anybody have any questions? Cool. Oh, and the other big announcement is Dominic Zerlo has been was temporarily relocated as the director of the Administrative Services Division. That time has come up that he is now coming back to our office full time starting October 14th. So he will move back into the director role, and then I will be the deputy director at that time, but he will be coming back to us. And then he's coming back for like 2 weeks, and then he's going on a 3-week cruise. So it's the best way to come back to your job, I guess. Okay, any questions? Thank you all very much.
Thank you for those updates. I appreciate your report. Okay, at this time, I would like to reach out to Chris Woodward, General Counsel. I am wondering about potentially changing the agenda and allowing some public comment earlier rather than at the end of the meeting. Is that something that we need to vote on as a board?
I would say that's sort of at the call of the chair. I think that the chair has the ability to decide the order in which you go on this. I think it's doable at your discretion.
Perfect. Okay, thank you. I just like to touch base with you. I appreciate your counsel. I'd like to propose to the board that we have a change with the agenda, as there were several pre-registrants for public comment that was related to this petition that was tabled at our last meeting for female orgasmic difficulty and disorder. What does the board think about introducing their comments at this time rather than at the end of the meeting?
This is Tracy. I support that.
I also do. This is Alan.
This is Bettina. Can you hear me now?
Yes, thank you.
Yay! I approve as well.
All right, perfect. So,
I do too. I just couldn't unmute myself for a second. This is Cindy Graveler.
okay, thank you very much for your flexibility with this. I would like to be able to proceed with public comment at this time. So individuals who have pre-registered for the meeting and have requested to make a public comment will be able to make a comment first and should limit their speaking time to 3 minutes. If you have not previously requested to make a public comment, please click on the raise hand icon on your computer or dial *5 if you're calling in by phone. And I ask for assistance from the Medical Cannabis Department with calling on the speakers and for monitoring the time. For those of you unable to make public comment during this meeting, the public comment period will be open for 48 hours after the meeting. Please send all public comments to medical.cannabis@state.nm.us. And also for the public comment, please refrain from introducing any new technical information as the window for that is closed. So thank you, Medical Cannabis Department, for helping with the public comment period. We look forward to hearing from you.
And Dr. Richmond, I have put the email address in the chat as well.
Perfect. Oh, that is not what I announced, so thank you.
It changed. It will still get the emails. This is just the changeover to the new email addresses. So you're fine. Yep.
Perfect. Thank you.
Okay, first we'll give time to Tanya Griffin. You will have 3 minutes to speak. We will give you a 30-second warning before your time is up, and your 3 minutes begins now.
She is not unmuting that.
Okay, one moment. At this time, she should be able to speak. Tanya?
I think yeah, guys, can you hear me now?
Okay, yes.
We can.
Okay,
Awesome.
and your 3 minutes will begin now.
Well, thank you everyone for everything that's about to happen. My name is Tanya Griffin. What you guys are doing in New Mexico is so important. I am a sex and cannabis expert, founder of Oh Yes. And I want to start by saying that the female orgasm is not a luxury, it's a necessity, a bodily function that promotes and serves overall health. Women, like men, have a right to pursue solutions for orgasm. So I appreciate all of you on this call. If we can push this forward. While FOD may seem trivial relative to some other disorders, I can assure you that it is not. We have to start somewhere. I am 56. I get prescribed estrogen, which, like cannabis, has invaluable benefits. My midwife had to note vaginal atrophy in my chart, in order to help me make decisions to solve issues around orgasm. I think we all have a right to do that. FOD is devastating when it is taken from you, and cannabis, dosed correctly, practiced and tracked, and of course studied, can positively impact suffering women. There are, of course, a number of theories relative to cannabis's impact, particularly in helping women reach orgasm, using cannabis to help break through mental barriers inherent in achieving orgasm. So I have worked with so many, countless women, and have personally tracked cannabis's use and its positive effects on orgasm for over a decade. And I understand that our goal here is to ensure that this natural bodily function is accessible to all women. So I just want to close by saying it is very good work. Thank you for listening to all of us on this call, trying to move forward in helping
30
all
more seconds,
women
Tanya.
have access to, thank you, just giving us access to what is a basic bodily function. Thank you all. And I'm done.
Thank you. Do we have any other public comments? No. Okay, next we'll give time to Nan Jacobson. Are you there? You should be able to speak now. Nan?
Your line is muted, Nan.
How about now?
Very good.
Sounds good.
Thank you.
So you'll
Hi.
have 3 minutes starting now.
Thank you. I'm a sex therapist and I'm a sex neuroscience researcher. For 4 decades, I've been seeing how effective cannabis can be for women who have not been able to experience orgasm. And it really does work. There's nothing out there. There's no prescribed medications that can help women. And I study how sensations get from the genitals into the brain. I do brain studies of stimulation, imagery, and orgasm. And I can tell you there's a number of mechanisms by which we believe that cannabis is effective. And again, I want to mirror that the capacity to have an orgasm is not a luxury. Women who cannot experience orgasm suffer significantly. So this works empirically, and we really need to have medical marijuana doctors be able to help women learn how to do this so that they're not trying to fly blind. And the bottom line is it's effective. So that was quick.
Great. Thank you very much. Okay, next up we have Jordan Tischler. I'm going to unmute you. Jordan, are you there? You may need to unmute yourself, Jordan. Jordan, are you there? They should have access to speak now. If you're still on the line, you may need to unmute your microphone.
Diego, they just put in the chat that they are here, but they said they are unable to. They're unable to unmute themselves, but I do see that they are unmuted on our end.
Okay. Would we like to come back to Jordan or see if
Yeah,
there's
let's come
another
back
way?
to Jordan. It looks like Jordan actually dropped out of the meeting. So
Okay.
maybe they're going to log back in. So I will monitor that.
Okay. Is there anyone else that would like to give public comment? Oh, there we go. Okay, Michael Schwartz, let me just allow your mic. You should be able to speak now, but just be sure to unmute your microphone. Michael, are you there?
Huh.
Same problem.
All right, let's go on to Susan Mulvihill and see. Oh, somebody is speaking. Yes, we can.
Michael?
Michael, we can hear you.
Okay, Michael,
Okay.
you have 3 minutes starting now.
All right, I'm a psychiatrist, a distinguished life fellow of the American Psychiatric Association, and a recently retired professor of psychiatry as well as humanities in medicine at Texas A&M. I have an unusual background. I've been involved in this topic since the middle of the 1970s when I joined the National Institute of the NIMH, which was at the time the leading lab studying psychedelics, how they work on the brain, what they do, ranging from marijuana to the strongest psychedelics to the one we have in our own brain. We were shut down, unfortunately, by the government at the time. And of course, the politics has been up and down, but I am very excited about the possibility of promoting this for this incredibly widespread and not very often discussed issue of female and orgasm. And I just wanted to tell you, just in the most brief sense, I wanted to give just a brief outline of what goes on. This is conceptual. It's not, no neuroscience, no theory, but what these drugs do and what marijuana does at a very small level is expand what is called the horizon of consciousness. Your consciousness, your awareness, the things you're talking about, the things you're involved with, has a horizontal structure. The things around you you're very familiar with, off in the distance is something else, and that's it, and it's limited. And imagine being a child growing up in the Midwest, and you can't see beyond the horizon of your farm. And then one day someone gives you a ladder, helps you climb a tree, and now you can see beyond the horizon. There's new stuff there. There's a mountain, there's a river, there's a city. Then you have what's called a reduction in complexity, and you bring it all back together, and you come up with a new way of seeing things. This massive reorganization of the brain is something that all of these drugs do. And the wonderful thing about marijuana, THC, is that it can happen to a small degree, when it's supervised, very carefully, very conservatively, and help this process be managed from beginning to end. Since I've been involved in this project, I've met many women, and I have been absolutely amazed at the candor with which they discuss things that
30 seconds, Michael.
people will not discuss. And I'm just very enthusiastic to help support this project. I'm out of time? Well,
You have about 50 more seconds.
okay, yeah. I would just say this notion of expansion of the horizon of meaning and the reduction in complexity can be difficult and even dangerous.
And that's your time, Michael. Thank you very much for your comment. Next, we will go to Suzanne Mulvihill. Suzanne, are you there? Suzanne, your mic should be open now. You just need to unmute it.
All right, Susan, try unmuting on your end because I do show you're unmuted on our end.
If you're having difficulty, you can always put that in the chat.
Yeah, everyone's lines are disabled until you're called on, and then once we allow the mic, you have to unmute yourself.
We will try to come back to Suzanne. Jordan, I believe you logged back in. Would you still like to make a public comment? Okay.
I'm not seeing that Jordan has logged back in, but
Yeah, I think he got back
okay.
off.
Okay. I do see Nan Jacobson has their hand up. So weird.
Okay.
I
Okay,
wanted to
Nan?
let you, I wanted to let you know that Suzanne was trying to get in and she was not able to unmute the mic. I told her where it was at the top and she said it wouldn't unmute. So there seems to be some, even on a computer, some technical issues. I'm suspecting maybe that's what's happening with Jordan as well.
Okay, thank you.
Maybe if we try making them a presenter, would that do anything, Kathy?
Yeah, it's worth a try.
We'll try that. Susan, we're going to try to make you a presenter and see if that works. All right, now try unmuting yourself. I do see that you are unmuted on our end and you've been made a presenter, so make sure you're able to unmute on your computer. So whatever mute services you use on your computer, make sure you unmute that.
Okay.
I don't know if we can hear you yet, though. Let me see. Can you
Okay.
say hello? There we
Hello,
go.
Suzanne?
can you hear me?
Yes,
Okay.
we can. Okay, great. You have
Okay,
3
so just so
minutes
you know,
starting now.
I can chat. I couldn't do anything in the chat, but I'm not going to spend time talking about that. Thank you for having the second meeting, this follow-up meeting. I wanted to share that Connecticut did approve adding FOD as a condition of treatment with medical cannabis in June. And I received an email the day after from a woman titled Help. And she said, I'm 76 years old. I haven't orgasmed for 30 years, and I've been married for 55 years. And she has since gone to get cannabis. However, she needs advice. That's why we need it to be medical, so that they're not trying it out on their own to figure out too much, too little. And that's the reason it needs to be medical. I also wanted to share that there have been 2 more studies that came out since mine in May. Dr. Tischler and I published our study that came out on May 7th, called The Assessment of the Effect of Cannabis on Female Orgasm Difficulty Disorder. And then there was a study by Dr. Lauren Stryker that came out about a month ago on women who are ameliorating their orgasm difficulty with cannabis who are in menopause. And at low doses, there was one out of Israel called Update on Human Sexuality. So I did want to read to you. There is a thread called Becoming Orgasmic on Reddit with 30,000 women. And this woman wrote just this past week, it's titled Orgasmic, but Only When High. So after 26 years of non-orgasm, both solo and with a partner, I've finally been able to finish while masturbating. This is great, but the only way I've been able to get there is by using weed. It's how I've been able to turn my brain off enough just to simply feel and not overly focus on the goal. I also have ADHD, so my brain is always running a mile a minute and I'm easily distracted. I'm not necessarily upset with using weed for this solo purpose, but I do not really want to be reliant, especially for partnered purposes. Does anyone have any suggestions? I mean, you can see over and over, and I will be submitting for public record a list of women who are struggling with orgasm difficulty and a list of women that I've extrapolated from Reddit who are using cannabis. So my hope is that it becomes a validated treatment, a condition of treatment, so that women can receive proper treatment, similar to what happened with New Mexico and PTSD when there was only one study that was done in New Mexico and it got approved for the veterans. And it's now a condition of treatment in many states. And my hope is that we will do the same for women with FOD. Thank you.
Thank you very much for your comment. Hey, are there any other comments? Anyone else that would like to public comment? Okay, we have Joanne Irvine. Let me unmute. Are you there? Again, you may have to unmute yourself.
I think since promoting to presenter worked, we should do that.
It actually looks like Joan has dropped out of the meeting.
No, she's there still.
Oh, okay. Try moving. I'll move her to presenter. See if that.
I already moved her.
Okay. Mr. Irvine, if you please make sure that you use whatever technique you use to unmute your microphone on your computer. Sometimes just unmuting it in Teams does not work. So make sure you're unmuted in your actual settings.
Okay, it should.
Oh, we heard you. We can hear you now.
Okay, great.
Yes.
So you can hear me.
Yeah,
Fantastic.
we can hear you. And
Okay.
so your 3 minutes will begin now.
Okay. Well, thank you so much for what you're doing. I'm out here in Los Angeles. I'm a doctor of clinical hypnotherapy. I did my thesis in the late 90s on using hypnosis for sexual enhancement. It was effective because we're talking about sexuality is both physical and mental. However, I found that, they came out with Viagra for men, have never come, and as women, we're going, yay, they did this for men. We're going to be having a drug that's going to help us soon too. And it has never happened. And so many women, it's just about getting into that mindset, but it's the body and the mind working together. And I had FOD most of my life. And I'll tell you, by adding cannabis and some other psychedelics, I was able to go from not having an orgasm maybe once or twice a year to having an orgasm all the time and knowing what that place is. And somebody said, it puts you in a place where you can focus, that your mind and your body are working together. And I'll tell you, one of my recent clients came back to me afterwards and said, you are my new best friend. And it just added to her pleasure. And that creates a connection with her partner. And so it's very important to relationships that people can share the sexuality and can have something that they know is going to be working for them. And the fact that you're working to make it medical, I think is fantastic, because it's important for the medical profession to be helping women with their FOD. And this gives you something to work with that's not been available before legally. So thank you so much.
Great, thank you for your comment. Okay, so let's see, is there any other
I do see that
comments?
Jordan is back in the meeting. Jordan, if you did want to make public comment, let us know. We have made you a presenter, so again, make sure you're unmuting on your computer system if you would like to make public comment.
Yes, I thank you for your attention to the technical side of things. Appreciate that very much.
Jordan, your 3 minutes will begin now.
Okay, thank you. My name is Jordan Tischler. I'm a physician and faculty at Harvard Medical School. I have done, my area of research is with Dr. Mulvihill on cannabis for sexuality and specifically for female orgasm disorder. As you guys hopefully know, we published a study on this some number of months ago. This is a pervasive issue. You've heard from other women and presenters here today. Up to 41% of women have an issue with this over the course of their lifetime. And as other presenters have mentioned, this is a substantial issue in terms of both the health and psychological burden upon women. I can tell you from my clinical experience that this is remarkably effective. You've also heard from others that there are no effective treatments at this point, and that unfortunately is true. Cannabis, on the other hand, again, when used meticulously, carefully in a prescriptive fashion, can in fact be very successful. And I have hundreds of women that I've treated at this point for this condition or for other conditions, and ancillarily have seen the results in their achievement of orgasm and their benefit from sexuality. So I will not take more of your time, but really urge you guys to take this seriously and to approve this condition for all the women in New Mexico. Thank you very much for your time.
Thank you, Jordan. At this time, are there any other participants that would like to make public comment?
All right, I do not see that anyone else has raised their hand to make public comment. Just as a reminder, the public does have the option of being able to submit public comment up to 48 hours after the meeting, and they can be sent to the medical.cannabis@doh.nm.gov for inclusion in today's meeting. Additionally, I would also like to note that an additional board member, Eileen Barrett, has now joined us. If she is still on the line, I would welcome. Thank you for joining us, and please introduce yourself to the group and give us some of your training and interest in the Medical Cannabis Advisory Board.
Hi, good morning. My name is Eileen Barrett. I am an internal medicine trained physician. I'm boarded in internal medicine, and also right now my clinical care is in the care of people with substance use disorders. And well, although I've been doing that for 19 years, but now it is nearly exclusively that is the case. And that I am also I live in Albuquerque. I am also I've been on the Public Health and Safety Advisory Committee for since its inception, and I'm presently chairing that. And my interest in this is that I'm also a substance use disorder and pharmacoequity researcher. That latter term is one that not everybody knows, but it is about overcoming the barriers to people receiving evidence-based care for substance use disorders. I hope that that was what you were looking for, Dr. Richmond.
Perfect. Thank you very much for joining us. I am glad you were able to sign on. Today, just to get you up to speed, we had some updates from the Cannabis Board and have completed hearing some public comment. And now for our next agenda item, we do not have any new petitions that were submitted since our last meeting in May. However, we did vote to table the petition for the addition of the female orgasmic disorder as a qualifying diagnosis for medical cannabis. The petitioners were notified that the petition was tabled and that it may be heard today. We are not going to be hearing any re-presentation of the petition, as we've already completed that portion in May and have reviewed the documents. If a petition is removed from the table, then a discussion will resume amongst the board. And if necessary, petitioners may be called upon to answer specific questions asked by members of this board. In order to untable a petition, it requires a motion to take the petition from the table. If there is a second, then a vote will be taken to confirm a majority to resume discussion of the petition. If there's a majority, then we'll discuss the petition, and after sufficient discussion takes place, then we will consider a vote. So is there a motion to take the female orgasmic difficulty disorder from the table?
I motion. This is
Rachel. Cindy motions to take the petition from the table. Is there a second?
I second that we remove the motion from the table. Sabrina Johnson.
Thank you. Sabrina seconds this. We will now perform a roll call vote to determine if the majority of the board wishes to discuss the petition of female orgasmic difficulty disorder. Please respond yes or no when called upon to indicate if you would like to take the petition from the table. Eileen Barrett.
Yes.
T. Kosei.
Yes.
Rachel Goodman.
Yes.
Cindy Griebler.
Yes.
Sabrina Johnson.
Yes.
Ellen Plymel.
Yes.
Stephanie Richmond, I vote yes. And Tracy White.
Yes.
Excellent. All right. By a vote of 8 of 9, the Medical Cannabis Board has voted to take the petition of female orgasmic disorder from the table for discussion. I look forward to hearing from fellow board members regarding this petition and open the floor to you. Yes, Eileen.
Thank you. Female orgasmic disorder is undeniably not only, of course, a real diagnosis, but also a condition that that needs to be treated and needs to be treated urgently, and that there are reasons that are just related to patient-centeredness, dignity, quality of life, and more. Specifically because of all these reasons, and because it is so crucial that in the spirit of gender equity and more, that people receive evidence-based care, I wish to orient and reorient the board that this is not presently an evidence-based treatment that is recommended from the American College of Obstetrics and Gynecology, which is the standard bearer for evidence-based treatment in the care of females. And it is also not one of the recommended therapies that is recommended by the American Urologic Association, who are the other professional society of physicians and non-physician clinicians who make the evidence-based recommendations after reviewing the quality and the scope of the data. There are known, neither of those organizations recommend this treatment, and there are known complications to making recommendations for any diagnosis, any therapy that is not widely evidence-based or that does not have the best evidence that is available for patients. And I would recommend at this time to the board that we continue to keep this on our, because of how important this diagnosis is, and because of the lack of broad evidence based on the at least 2 professional societies that have over 80,000 members, that we continue to monitor for the development of further evidence to support this indication for this qualifying condition, but that we not do so at this time.
Thank you for those comments, Eileen. I appreciate it. I'd like to hear from other board members regarding your input.
This is Cindy Griebler. I respectfully disagree, and I feel that one of the main reasons why there hasn't been the kind of robust research that people have been talking about is exactly that cannabis has not been legal and has not been involved in trials. Currently, it's involved in a lot of trials. But I think that the researchers who are at the forefront of this disorder agree that this is a very good use of cannabis. And I would just like to say that I think that this should be on the list of proposed uses and should be approved by this Medical Cannabis Board. Having read a lot of information sent by those petitioning and also other information about the diagnosis, and I feel that this does a disservice to women because just like everybody was all excited about some of the medical forefront that men had with orgasm disorders, it seems like that research in women sort of stopped. And I feel like that's like right now with all of the things that have come out recently, that this would be an excellent addition as a diagnosis. And with a medical provider helping patients to address this issue so that they can do it safely, I think that is a really good option.
Thank you for your comments, Cindy. I appreciate it. Any other comments? Yes, Eileen. Thank you.
Thank you. I wish to point out that there are no barriers, or there aren't barriers at this time for people whose providers wish to make a recommendation for cannabis, because cannabis is legal in New Mexico, so that people are able to get it if they need it. The reason why I would recommend caution at this time is because this science is still actively evolving, and there are known complications of using any pharmacotherapy or any therapeutic agent, particularly those that are centrally acting, and that can have an addiction potential. But even if it don't have the addiction potential, but in this case, one that is known to, that there are consequences for having the imprimatur saying something has a medical indication when there's a not clear consensus that it does. I understand that with the available evidence that was present at the time to the Cannabis Advisory Board, that the decision was made to have PTSD as a qualifying condition. It also is the case, as that is a representative example, that that there is robust evidence that cannabis can make PTSD worse, and that there are other agents that are more that are safer in many patients. And that is one of the reasons why the American Psychological Association, which is the largest, I believe has almost 60,000 members, or Psychiatric Association, excuse me, does actually not at this time recommend cannabis for PTSD, and neither does the American Society of Addiction Medicine. So to wrap that up, I would ask us all to remember that we can continue, this is not our only chance to do the right thing for women, that we can revisit this as the science is emerging. And in that context, while that science is emerging, we can know that this small number of people with a great deal of experience in treating people who have female orgasmic disorder, who are not experiencing the benefit that they deserve from the current best available evidence as recommended by the American College of OBGYNs and the American Urological Association, that they can still get that care because cannabis is legal in New Mexico. Thank you for the consideration. Oh, and forgive me, I think it was also, people saw one of the recent articles from the New England Journal that was about treating women with sexual dysfunction, and this was also not one of the recommended treatments.
Thank you for those comments. Yes, Rachel, please. I look forward to hearing your perspective. Perhaps Rachel is having some technical difficulties.
My bad. I was talking and it wasn't unmuted. Okay. So thank you. Yeah, so my perspective comes from a couple different angles. The first I'd like to address is that I think that if the board, if we were to have followed all the recommendations from all of the individual boards from the different fields, I don't think that the medical cannabis program would be anywhere near where it is today, as robust, and we would not be helping as many patients that there are. One thing that I always go back to is that to have a lot of trust in our patients, and a lot of our patients with medical cannabis are using this to treat something specific. They will self-dose and usually self-regulate, and with guidance of a medical practitioner, but often if they're treating a specific issue or not abusing that in any way. So I want to take that off the table for the patients. I think that if, I'm a member of ACOG, I'm a fellow of ACOG, board certified through ACOG and ABOG, and also now a menopause practitioner. I just got back a couple weeks ago from the Menopause Society meeting, and which is far ahead of where ACOG is. If I were to follow ACOG's recommendations in my practice now, I would do many women a disservice for their menopause care. We know that ACOG can be many years behind where we are. So while I respect ACOG and support many of the recommendations, it does take a lot of time for them to catch up to certain things. I think it is, so I would say that if ACOG isn't recommending this, I would not use that as a reason for us not to. I think as our job is to, and we have gone out on the limb before with other recommendations that we have made, and with some evidence and helping patients to treat their specific disorders, and many have benefited. So I would strongly recommend that we add this to our list of qualifying conditions. I think it's wonderful news to hear that Connecticut has done it. and set a precedent. I was hoping that would be us, but I would like to strongly voice my support for adding female sexual dysfunction to the list.
Thank you, Rachel. I appreciate that. I also see that Tracy has her hand raised.
Thank you. Yeah, I would echo Cindy and Rachel. I think that, you know, a lot of our uses in the medical arena have been from survey-based data, because that has been oftentimes some of the best data that we have, at least, you know, with limitations in studying this the way that we do prescription medications. So I thank Dr. Mulvihill and colleagues for what they have done. I would have loved to have seen some section on adverse events, like if there was any reports on side effects that patients experience. But I do think that, you know, having this under the medical conditions can help patients decide, you know, kind of their own risk-benefit discussion. And I think, you know, cannabis is mentioned in the ASCO guidelines, the American Society of Clinical Oncology. Certainly not fully supported, but, you know, kind of akin to that, we use it in a lot of oncology conditions as well, without the full support of our guiding principles. Thank you.
Thank you, Tracy. Eileen, I see that your hand is still raised. I'm not sure if that is from before or if you have additional comments. Perfect.
My apologies, none, thank you.
No worries. I'm just wanting to make sure that everyone is able to provide an opinion regarding the inclusion of this diagnosis. How about from other members of the board? Would anyone else like to make comments? I also had reviewed many of the petition submission and understand that this is an important diagnosis for women to be able to have treatment options for. I also understand from Eileen's perspective that there is some ongoing emerging science, and also appreciate those that have made comments for this diagnosis to be included, that it's some previous diagnoses that have been approved were not always in alignment with society guidelines that have been suggested. So many of the different studies that were mentioned in this petition had some robust survey data for women, and I appreciate that there has been some positive impact for women using cannabis for FOD. At this time, I am wondering what the board thinks about how this diagnosis needs to be separate from anxiety or pain or PTSD.
Stephanie, to comment on that, I think sometimes the presenting symptom might be only female sexual dysfunction, but it could be it's one of the other diagnoses, but they might not be able to get it approved for something else if this is their presenting symptom. I've asked around to a couple gynecologist friends, and much similar to our board members with the same background, very in favor of using this for this diagnosis and side effect profile in patients. And if you think about our general population, 50% of our population has depression or anxiety and is on an SSRI or some form of treatment. So just looking at our overall population, these are the options we have to choose from. So separating out this diagnosis, if this is their primary cause of dysfunction and poor quality of life, removing this or not adding this as a diagnosis could potentially impact many patients' lives without having this as an option and feeling comfortable that it is prescribed and they're not doing something rogue or illegal, that they feel that it is a safe treatment that has been researched with good data showing that it is effective, that this isn't just something we're throwing at them because we have nothing else. All the research from backgrounds of everybody who's spoken so far has said from a psych perspective, which is very important, as we all know, to our overall health, that everybody has been in favor for their patients of this use of cannabis for this diagnosis.
Thank you for that information. I appreciate it. I also appreciated from the petition submission supporting documentation that there have been some suggestions as to how cannabis may be something that helps with this diagnosis. What does this board think about any kind of unique pathways that are helping for this diagnosis in particular, outside of anxiety or pain?
So I think what you're asking is if the primary diagnosis, like we said, is for the sexual dysfunction and inability to achieve orgasm, and if the cannabis can help lower that barrier and achieve orgasm separate from a reason of not being able to that excludes anxiety and pain, then there's a benefit there. I believe that's what you're asking. So to clarify, it seems to me that that can be a single diagnosis that is separate from not being anorgasmic from anxiety and pain. There can be a separate diagnosis.
Thank you. Any other thoughts on the other board members?
Hi, this is Cindy Griebler. I agree that there doesn't need to be pain or anxiety or PTSD for some patients who have this issue. And I think that those are the people who might be less likely to try this, less likely, even if it's, because if it is an indication and it's something that can be helpful, I think that we'll see more people being open to that as an option, as a treatment option, which could be very beneficial.
Thank you, Cindy. Yes, Eileen.
I actually wasn't going to answer explicitly the question that you asked, but just to point out that generalized anxiety disorder, I understand why the decision was made to have that one of the conditions, qualifying conditions, but the evidence is really mixed and it can make general anxiety disorder worse as well. And it's not a recommended treatment. Cannabis is not a recommended treatment. And one of the, I will level set about that, which is that there are people who have generalized anxiety disorder, for whom cannabis helps them. There are people for whom it makes it worse. And then there are people who we can't even know because it's not regulated what people are getting. I mean, there are broadly safety regulations, but there's such different different dosages and different changes with formulations in the active ingredients that it's there isn't a required training that could match someone who is in the dispensary or for any of the medical providers for how to even instruct anybody, for any patient, for what dose, frequency, brand, potency, any of those features. Thank you.
Yeah, I agree with that. With some of the studies with survey responses, some people that may not have tried this as a diagnosis or weren't regular users of cannabis, correct me if I'm wrong, but one of the studies suggested that those individuals didn't have necessarily an improved response. And other studies showed that, in that same study, other respondents had good response and reported an increased response of successful orgasm with increased dosing and increased use. So I agree that there seems to be this would pose some challenges of how the patients would be guided at the dispensary level, in addition to with their providers for specifics. But on the other hand, I also think that statement could apply to any of the qualifying diagnoses that we currently have.
I'd like to comment again briefly.
Sure.
Some of this, all things that we prescribe have positives and negatives that you have to weigh. But if we are prescribing this, we should be treating it like a very dangerous, because it could make problems worse, medication. But following up with the patient and counseling very closely as to, okay, you have anxiety, this could make this worse, just like you would with any other thing that we do. But the issue to me seems more like maybe the prescribers aren't following up and guiding close enough. And yes, that is one of the hardest things right now with our medical cannabis is you can't be exact because strains and supply changes so much, but you can give very good general guidance knowing your patient's past medical history and all of their issues. You should be able to counsel and guide and help your patients microdose and manage a side effect and tell them what to watch out for, so that if something does occur, you discontinue and decide it's not the right medicine if it's something you decide to try. But the issue, you're right, it's very tough because it changes in the milligrams and the oral versus inhaling is much different. But all of those modalities also give us room to play to be able to guide to minimize side effects as well as the strains and the hybrids. So if we're prescribing, maybe we need better education on those of us who are prescribing, so that this should be safe, because it should be very safe as in any form of treatment, but this diagnosis specifically. And this subset of people, it should be very easy for us to help manage any potential side effect that may occur with this treatment that we are suggesting as a possible treatment for female sexual dysfunction.
Thank you. I appreciate the conversation. I just want to be able to provide time for anyone else that may be interested in giving their opinion.
I would just like to echo what was said. As physicians, there are lots of medications that we prescribe off-label that we know work. I mean, gabapentin prescribed off-label for neuropathy, and there's a large list, but that comes to mind. So it's one of those things that if it's something that's a thoughtful process between patient and physician, and we discuss the fact that these are possible side effects, this is, a way to address those things. Getting back to the anxiety and PTSD, like especially with anxiety, there are patients who do much better with indica as opposed to sativa, and there are certain qualities in sativa that can activate people and actually make them more anxious. So there are ways for us to have an intelligent conversation with our patients, make sure they understand, just like any prescription drug that we're giving them, what the pros and cons are, the fact that there right now is not a huge evidence-based literature that is going to support this use, but there are a lot of physicians who use it and there are a lot of patients who benefit. So I think it's up to the physicians to really make sure that we can get this information to our patients and let them know what our specific guidelines are, and that we have open lines of communication so that they can speak to us about what's going on and feel comfortable if they have side effects, so that we can make sure that they're safe.
What would those specific recommendations in your practice look like, for example, when you are suggesting the use of cannabis for FOD?
Well, I think that I think it totally depends on what the patient's experience with cannabis is. For some people, it's a novel medication, compound, whatever you want to call it. And so their receptors are going to be very different from patients who have tried cannabis before. So, starting at extremely small doses and seeing what their response is. I think that it would really depend on the patient and what they were comfortable with.
Thank you. Any other comments? If the discussion has been sufficient, then at this time I motion to vote on a petition for the 2024-001 add female orgasmic difficulty disorder as a qualifying diagnosis. Is there a second?
Second.
Rachel seconds. We will now perform a roll call vote. Please respond yes or no when called upon to indicate if you would like to have this petition added. Eileen Barrett.
No.
T. Kosei.
Yes.
Rachel Goodman.
Yes.
Cindy Griebler,
Yes.
Sabrina Johnson,
Yes.
Alan Plymouth,
Yes.
myself, Stephanie Richmond, I am voting no. Tracy White.
Yes.
All right, by a vote of 6 of 8 present Medical Cannabis Advisory Board members, the vote has been to add the petition of female orgasmic disorder as a qualifying diagnosis. Historically, as the chair of this advisory board, I have been the one that has written the proposal to the Secretary of Health. As I was a dissenting vote, I look to those that had voted in favor of this to spearhead the proposal that can be submitted to the Secretary of Health. Are there any volunteers? Ooh, yes, hang on. I see Eileen raise her hand. Yes, please.
Actually, thank you. I have a question about the process, which is that does the proposal then come back to the committee for review?
So the board has voted to add this. Now we have recommendations that get submitted to the Secretary of Health. The Secretary of Health then reviews it and has the final disposition for whether or not to add this as a qualifying diagnosis.
Thank you. Specifically, I wonder if that first step, if I can best understand, which is that when the recommendation is set forward, that just the language of it, is that something that that our group reviews? Because I believe that there could be some nuance there. Perhaps not. Perhaps not. Perhaps it is truly straightforward, which is this is the diagnosis, and then that's it.
Yes, in the past with the proposal that is submitted to the Secretary of Health, it has included the research that was submitted to the board's perspective, and why we have chosen to support the diagnosis. So yes, that has not historically been a group effort. It was something that I had previously written and submitted based on the conversations that we had as a board.
If I may, thank you. I would suggest that I think that your experience there will actually be really important, so that yours plus someone or multiple people who voted for it, I think will actually be incredibly important. I'm not wishing to add more work to you. I promise that's not my intention.
Oh, no, I get it. No, I totally appreciate that. No, I'm happy to help assist those that would be interested in spearheading these efforts. Yes, Rachel.
I was going to ask Andrea, do we have a precedent for the board chair not wanting to write the recommendation that did not as a dissenting vote? Because that to me seemed, I mean, it was you're our speaker in our head, and it seems that I don't know if you're concerned you would write a biased recommendation. Is that the concern, or has this happened before?
It hasn't happened before since I have been the chair, and I'm not unloading it entirely onto anyone else, but I think having some feedback from those that had voted for the written proposal to be submitted would be helpful from my perspective.
And I can tell you that we've not had that before where, I'm going to be honest with you. I don't believe in the chair that we've had in the past. We've had a situation where the chair who's responsible for writing the report has had a negative vote regarding adding a petition. Because typically the recommendation will just highlight the discussions that occurred, that there was a recommendation to add it. The secretary typically will look over the research, and, you know, and review the discussions that were had. But yeah, I do understand, I believe where Dr. Richmond is coming from of making sure that we do have that represented the accurate discussion about who those in favor and those that are opposed, so the secretary can see both sides. But we've not, to answer your question, Dr. Goodman, in the past, we've not had where, you know, the chair voted no, so therefore wanted to have somebody else take the lead on that. But there is no requirement that the chair actually does it. It just has to come as a recommendation from the board.
That is correct.
Got it. Maybe since you've written some before, you could write it up, and then you could email it to all of us to review if there's something to add or feel that there's not. Would you feel comfortable doing that?
Let me just ask Dr. Woodward, sorry, Chris Woodward, our attorney, if that would doing that, if that would be impacted by open meeting law.
Yeah,
No,
probably.
I think you're all right on that. OMA technically doesn't apply to this board, which is an advisory board and not a policy making board. And the rule doesn't really say much about the report other than that the advisory board shall provide to the secretary a written report of finding, which either recommends approval or denial, and that expresses sort of the medical justification for it. So I think how the report is done is kind of up to the board and up to the chair. If the chair prefers to delegate it to someone, I think she can do that. If she prefers to draft it and circulate it to others to see if everyone is okay with the verbiage, I think she can do that as well.
Great, thank you, Chris.
So I am looking to those of you in the majority that had approved this diagnosis. I encourage you to put down some of your thoughts on paper, send it to me in an email draft, and we can work perhaps with the Department of Health to use our SharePoint format to put some of your reasons why this is something you would like to have approved to that site. And then I can, after reviewing that information and writing something up as a final document, I can then post it to everyone on the SharePoint that we have. But I am looking for someone else to spearhead this, with me being a collaborative partner. All right. Thank you very much for your time. It's always a pleasure to work and participate on this board, and I appreciate all that you do for your work in with patients and medical cannabis. At this time, I'd like to propose that we discuss dates for our next Medical Cannabis Advisory Board meeting. I suggest sometime in April or May for our next meeting. Would April 14, 21, or 28 work for this group?
This is Alan. I'm good for either one of them.
What were the dates that were proposed?
April 7, 14, or 21. Those are all Mondays in April. Sometime in April after the legislative session is over, which ends like in late March of 2025.
Yeah, I usually get my schedule afterwards, so that will be interesting. Yeah, so I think we should just choose a date that everybody likes, and if there are issues, like, we can get back, I guess.
Yes, Eileen.
Thanks. I was going to ask is if we are required to set the date right now for the next meeting, or is that something that we can wait until, say, for example, after the first of the year when more people know when their schedule is, what their schedule will be like? And I support either way. I have no contraindications to any of those dates.
We're not required to, but in the past, we've, what we're required by law is to meet twice a year to consider petitions as what the regulations are. But in the past, we found that trying to get something on the schedule earlier, because I know you all are extraordinarily busy, it tends to help with folks. But you tell me if that's correct or not.
Yeah, I think historically we have scheduled it farther in advance at the end of our meeting, just so that we can all have it on our books. So I propose then, and if something happens, then we can always see about with ample time being able to reschedule that. I propose that we have our next meeting on April 21st. Is there a second?
So moved or seconded.
Thank you, Eileen, for seconding our motion to convene this meeting on April 21st at 9 o'clock. And we will have public posting 1 month prior. That's something that needs to change. We can certainly have a conversation amongst our boards through the Department of Health. It is now 10:48 on October 7, and I motion that this meeting is adjourned. Is there a second?
Second.
Did I just ask a question?
Yeah, sure.
So, for the yays for this proposal,
yeah.
So what was the conclusion? Because I think it would be good for maybe for us to have a conversation like together and put together something that's.
Yes, I was proposing that we, the Department of Health had previously put together SharePoint space for the petition information to be uploaded that we all have access to. I propose that we have a working document or that each of you in favor write why you are in favor of this. Submit it to Dr. Gary French, who can put it to the SharePoint for all of us to be able to review. And once input from those that say yay, yes, has been approved, I can write up a document, also share it to put it on the SharePoint prior to submission to the Secretary of Health.
Okay. That sounds good. And we all have we all have each other's contact information through the board, correct?
Correct. Yes, and that's the other reason why, just for ease of everyone being able to use the shared space of the SharePoint.
Okay.
So.
Okay. Great.
So one caveat to that, Stephanie, is that Gary is out for the next 2 weeks, I believe. Y'all should have access directly to the SharePoint site that you use for reviewing the petition information. So I would just encourage you to create your notes there so that he isn't a bottleneck unnecessarily.
Okay, perfect. Perhaps if that access could be redistributed for the board members, that would be very helpful.
Will do.
Perfect. Get started on it. I can also post to that area some of the previous documentation that has been submitted to the Secretary of Health as well. All right. Any other questions from the board? Perfect. Right, so it's now 10:51 on October 7th, and I motion that the meeting is adjourned. Is there a second?
I'll second it.
Thank you, Ellen. Ellen seconds. Thank you for your time and participation. We'll see you on April 21 at 9 o'clock, or please reach out to the Department of Health if changes occur that you would like to have a different meeting time. Thank you.
Thank you all. Have a good day.
You too.
Thank you.